as I mentioned before, habitual DUI offenders are seldom clinically depressed. Probably only 2% of them are depressed. But if they are depressed indeed. They are somewhere in the rock bottom of depression where they don't care if anything happens to them. They're desperate. But what I do, every time I see the client the first time for assessment, I have a bunch of paperwork. And if there is any indication in the paperwork that the client is depressed, I immediately give him or her the Beck Depression Inventory, and I trust this test and go from that. If one is depressed, I make a referral or try to introduce the idea of seeking psychiatric help the best I can. And I'll give you an example. One time I saw a client for assessment, and the agency policy is to kick out of the office anyone who seems to be under the influence. She was. But she was so severely depressed that to kick her out is to doom her to suicide. So I completed the assessment against all the rules. I made all the recommendations, and she was struggling. But eventually she got help from Clear Foundation. But if there is any indication at the time of your assessment that one is depressed, do your best. Do your best to help the person, because you don't know what's going to happen to him or her once they're out of your office. They might go out and check themselves out.
Michael, you mentioned that you make a referral. What do you use for referrals when you give someone a Beck Depression?
Okay. I immediately try to find out if one has a health insurance and what it covers. Now, also, some people who come to drug and alcohol counselors are in therapy already. And what is troubling here is that some therapists never ask or acknowledge the fact of substance abuse. If you have a substance abusing client in your therapy, treatment, or whatever, and one continues to use or drink, you're wasting his time, your time, and money. One has to be clean and sober first for any other treatment for anything ever. Thank you.
Okay, thank you. Okay, we've heard from a nurse and a substance abuse counselor. How about someone from another? Go ahead. Oh, sorry.
Okay, I deal every day with moms, postpartum depression mostly. It is very difficult for us to find out through the pregnancy because of the hormone imbalance and all that. But once they have the baby, what we do, we right away use we call the PHQ-9, and that's where we base ourselves. And as we do the math and we see the results, that he says we look for resources, which is very difficult because we usually, it needs to be in some type of crisis or have other mental issues in order for them to be taken. But what we do, we try to call and find places for them they can receive some type of therapy or if they need medication. But our first step is to do the assessment and try to do the correct and knowing that it's not only something that's the postpartum blues instead of postpartum depression.
Okay. Anyone else from another discipline?
If I could recap just for a second.
I'm sorry.
That's all right. Resources for the pregnant or the newly delivered mother, there are not too many. There's not, the status in our community is that there's not many places to go.
We don't have much either.
Yeah, in the work that I do, I'm a marriage and family therapist intern. After doing the assessment, find out a little bit more about the depression, the onset, if there were any specific triggers or that occurred just prior to the depression symptoms. And then also, because the model that I work from is strength-based, I want to know all the things that they've done in the past that have worked to decrease the depression and build on that. So trying to identify triggers and then building a treatment plan to increase their coping with the depression.
So if I could recap, using a strength-based approach to try to increase their coping skills.
Okay.
At St. John's Well Child and Family Center, when a patient comes in, they usually tend to see the primary provider. They report some depression, or either the provider screens for depression by using a PHQ-9. Then there's a warm handoff that's done to the clinician, which is myself. And then from there, I meet with the patient, go over the PHQ-9, and begin some CBT immediately. Defining what depression is, what the symptoms are, also addressing their strengths, but ensuring and recognizing their strengths so that they can themselves start to do some self-action or start addressing depression, and then following up with appointments bi-weekly.
Okay. So you actually are one of those resources that folks would refer to.
Yes.
Okay, how about someone else in another discipline that you run into? Are there any, like, doctors here or nurses? Nurses? Oh, you talked about it already. Anyone else? How about the faith-based community? We talked to a nurse from the faith-based community, but someone else from the faith-based community. Do you encounter folks with depression, and then what do you do?